Hello everybody. The topic for today's ESDO Learning Bytes is why and how to test for germline BRCA mutations in pancreatic cancer. I'll start with some background information on BRCA. The breast cancer susceptibility genes 1 and 2 are DNA damage repair genes that play a crucial role in maintaining genome integrity. DNA damage can occur on only one strand of the double helix, a single strand break, or on both strands, as double strand break. As you can see in these illustrations, there are two major pathways to repair DNA double strand breaks: the homologous recombination and the non-homologous end joining pathway. The homologous recombination pathway uses the nucleotide sequence from the undamaged duplicate sister chromatide as a repair template, so it is a very accurate repair process. In the non-homologous end joining pathway, both DNA ends are joined without consideration of homology, so it is a fast but error-prone repair process. As you can see, BRCA1 and 2 are involved in the very accurate homologous recombination repair pathway. Deleterious BRCA mutations lead to homologous recombination deficiency, where cells have to rely on the error-prone non-homologous end joining for repair of double-strand breaks, which accumulates DNA errors and causes genomic instability. Carriers of deleterious germline BRCA mutations have an increased lifetime risk for cancers. The lifetime risk of developing breast cancer is over 60%, and it's up to 58% for ovarian cancer and 5 to 10% for pancreatic cancer. The incidence of germline BRCA mutations in PDAC patients is approximately 7.5%, but the distribution varies regionally, so the incidence is higher, for example, in Israel and in Jewish ancestry populations. Germline BRCA is the most frequent mutation in familial PDAC. Let's take a look at homologous recombination repair deficiency beyond BRCA. Somatic or germline mutations of DNA damage repair genes are found in up to 20% of PDAC patients. The most common DDR mutations are RTM, followed by BRCA1 and 2, and several more. DDR mutations cluster particularly in familial PDAC. Familial PDAC is referring to families with at least two first-degree relatives that are affected by PDAC, and it accounts for up to 10% of all PDAC cases. About 10 to 20% of patients with inherited PDAC have identifiable germline mutations, most commonly in DNA damage repair genes, but also in mismatched repair genes or classical cancer susceptibility genes. Now, the important question is, why should we test for germline BRCA mutations in clinical practice? Evidence exists that BRCA mutated cells are particularly sensitive to platinum therapies and PARP inhibitors. So, identification of a germline BRCA mutation has immediate treatment implications. For proven germline BRCA mutations, guidelines recommend a platinum-based induction therapy, preferentially with FOLFIRINOX or gemcitabine with cisplatin or oxaliplatin, and a maintenance therapy with a PARP inhibitor, olaparib, in platinum-sensitive PDAC. Why are BRCA mutant cells particularly sensitive to PARP inhibition and platinum treatment? PARP is a DNA damage sensor and signal transducer that binds to DNA single-strand breaks. PARP inhibition impairs the repair of single-strand DNA breaks by disrupting the base excision repair pathway and also by causing PARP trapping through inhibition of autopyrylation and PARP release from the DNA. Unpaired single-strand breaks eventually accumulate into DNA double-strand breaks that cannot be repaired in HRR-deficient cells. Platinum derivates lead to covalent cross-linkings of the DNA that induce double-strand breaks that again cannot be repaired in HRR-deficient cells. Let's take a look at the evidence we have for the efficacy of platinum-based therapy in BRCA mutant PDAC. Up to now, it's mostly retrospective case control studies that suggest a survival benefit for BRCA mutant PDAC patients compared to BRCA wild-type patients receiving a platinum-based chemotherapy. While these results are mostly promising, the retrospective nature has, of course, limitations, and the platinum-based therapy used in the studies includes a variety of regimens such as gemcitabine plus cisplatin, gemcitabine plus oxaliplatin, FOLFOX or FOLFIRINOX. To date, there have been very few randomized prospective studies. A recent phase II randomized trial investigated cisplatin and gemcitabine with or without veliparib, a PARP inhibitor, in germline BRCA or PALB2 mutant PDAC patients. Response rates were high for both arms, even if it was not significantly different with or without the PARP inhibitor. So we still need randomized trials to confirm the observations that platinum-based chemotherapy has a benefit over other chemotherapy regimens such as gemcitabine and nab-paclitaxel, and it is unclear whether or not FOLFIRINOX or gemcitabine plus cisplatin or oxaliplatin should be preferred. The evidence of the efficacy of the PARP inhibitor in germline BRCA mutation is mainly based on the results of the POLO trial, a large phase III randomized trial. Patients with metastatic PDAC and germline BRCA 1 or 2 mutation who had not progressed after at least 16 weeks of first-line platinum-based chemotherapy were randomized into a maintenance therapy with olaparib versus placebo. The primary endpoint was progression-free survival. Secondary endpoints were overall survival, objective response rate, and safety. As you can see here, a significantly longer progression-free survival rate was observed in the olaparib maintenance group of 7.4 months versus 3.8 months in the placebo group. There was, however, no significant difference in overall survival. Olaparib demonstrated a manageable safety profile. This data led to approval of the FDA and EMA for olaparib as a maintenance therapy in germline BRCA mutated PDAC patients. Returning to our initial question, why should we test for germline BRCA mutations? Based on the data we just saw, a germline BRCA mutation has immediate treatment implications. Current guidelines recommend a platinum-based induction therapy followed by a maintenance therapy with olaparib in platinum-sensitive PDAC. Furthermore, we should offer genetic counseling for patients with germline BRCA mutations. For one, screening for secondary cancer in PDAC patients who are in remission can be considered. More importantly, mutation carriers among relatives can be identified, and a cancer screening and prevention strategy can be discussed. Another important question is, how should we treat somatic BRCA mutations or non-BRCA DDR mutations? Based on the current knowledge, a platinum-based therapy may be offered or participation in a clinical trial. Who should we test for germline BRCA mutations? All newly diagnosed advanced PDAC patients fit to undergo anti-cancer treatment, ideally at the time of the primary diagnosis. How should we test? By using a blood sample or tumor tissue sample. The gene panel should include at the minimum the following genes, or even better, a broader testing strategy as proposed by the ESDO expert panel that consists of several somatic and germline DDR genes. To summarize, here's an algorithm for clinical decision-making as proposed by the ESDO expert panel. Who should we test for germline BRCA mutations? Advanced PDAC patients who are fit to undergo cancer-specific therapy, ideally at the time of the primary diagnosis. How should we test? By using a gene panel that includes somatic and germline BRCA mutations and ideally other genes involved in the HRR pathway. Why should we test? In case of a proven pathogenic germline mutation, patients should receive a platinum-based chemotherapy or participate in a clinical trial. and receive an olaparib maintenance therapy in platinum-sensitive patients. In case of a proven pathogenic somatic mutation, the recommendation is a platinum-based therapy as well, or participation in a clinical trial. Thank you for your attention.